This lesson is on allergic rhinitis. Allergic rhinitis is an inflammatory disorder of the nasal mucosa, which is characterized by nasal congestion, runny nose, itching, sneezing, and sometimes conjunctival inflammation. It's a common chronic disease affecting 20 to 30% of children. The symptoms may appear in infancy, with the diagnosis generally established by the time the child reaches age 6 years. When we came to risk factors for allergic rhinitis, the first is having family history of atopy, such as bronchial asthma and eczema, and also children whose mothers smoke during the pregnancy and also even after delivery. Those with heavy exposure to indoor allergens, and also delivery by cesarean section is associated with allergic rhinitis and atopy in children with a parental history of asthma or allergies. When we came to protective factors for allergic rhinitis, the exposure to dogs, cats, and endotoxin early in childhood protects against the development of atopy, including allergic rhinitis. Breastfeeding, not necessarily exclusive, is beneficial. So breastfeeding is very important in preventing a lot of allergic disease, a lot of atopy, such as bronchial asthma and eczema. When we see classification of allergic rhinitis can be classified based on the duration of symptoms as seasonal or perennial. Seasonal means intermittent. In this case, the symptoms occur for less than 4 days per week for less than 4 consecutive weeks. Whereas perennial or persistent symptoms occur when the symptoms persist for more than 4 days per week and greater than 4 consecutive weeks. Allergic rhinitis can also be classified based on the severity of the symptom. We can classify it mild to moderate and severe. Mild allergic rhinitis is where the symptoms are not troublesome, the sleep is normal, there is no impairment in daily activities, there is no incapacity at work or school. Whereas the severe form is when the symptoms result in sleep disturbance and impairment in daily activities and school performance. Inhaled allergens are the main cause of all forms of allergic rhinitis, both intermittent and persistent. Airborne pollen responsible for exacerbation of intermittent allergic rhinitis appear in the distinct phase. For example, tree pollinate in the spring, grasses in the early summer, and weeds in the late summer. Whereas persistent allergic rhinitis is most often associated with the indoor allergies, house dust mites, animal danders, mice, cockroaches, cat and dog allergies. When we see the pathogenesis, the exposure of an atopic host to an allergen leads to the production of serum immunoglobulin E. Then the clinical reaction or re-exposure to the allergen are classified as early phase and the late phase. Early phase occurs within the first 10 to 20 minutes, whereas the late phase occurs after 4 to 8 hours. Bridging of the Ig molecules on the surface of mast cells by allergen initiates the early phase allergic response, characterized by degranulation of mast cells and the release of preformed and newly generated inflammatory mediators, including histamine and prostaglandin. Whereas the late phase allergic response appears after 4 to 8 hours following allergy exposure. In this case, inflammatory cells, including basophils, eosinophils, neutrophils, mast cells, and mononuclear cells infiltrate the nasal mucosa. When we see the clinical manifestations, the diagnosis of allergic rhinitis is based on symptoms in the absence of an upper respiratory infection and structural abnormalities. Typical complaints include intermittent nasal congestion, itching, sneezing, clear runny nose, and conjunctival irritation. And these symptoms increase with greater exposure to the responsible allergens. The patient may lose their sense of smell and taste, and some experience headaches, wheezing, and coughing. Nasal congestion is often more severe at night, inducing mouth breathing and snoring, interfering with sleep and arousing irritability. Children with allergic rhinitis often perform the allergic salute, an upward rubbing of the nose with an open palm or extended index finger. This maneuver relieves itching and briefly unblocks the nasal airway. It also gives rise to the nasal crease, a horizontal skin fold over the bridge of the nose. They can have allergic gape, which is a continuous open mouth breathing, and allergic rhinitis, which is a dark circles around the eyes. A nasal exam may reveal clear nasal secretions, edematous, boggy, and a bluish mucous membrane with little or no erythema, and a swollen turbinates that may block the nasal airway. Thick, purulent nasal secretions indicate the presence of infection. When we see the complications of allergic rhinitis is associated with complications and comorbid conditions. Undertreated allergic rhinitis detracts from the quality of life, aggravates asthma, and enhances its progression. Children with allergic rhinitis experience frustration over their appearance. Allergic conjunctivitis is reported in at least 20% of the population and greater than 70% of patients with allergic rhinitis, most frequently in older children and young adults. Chronic sinusitis is a common complication of allergic rhinitis. When we see the laboratory findings in allergic rhinitis, a percutaneous skin test provides the best method for detection of serum Ig with a positive predictive value of 48.7% for epidemiologic diagnosis of allergic rhinitis. To avoid false negative results, Montelukast should be withheld for 1 day, most sedating antihistamine preparation for 3 to 4 days, and non-sedating antihistamine for 5 to 7 days before doing this procedure. When we came to the treatment, safe, effective prevention and the relief of symptoms are the current goals of treatment. Specific measures to limit indoor allergen exposure may reduce the risk of sensitization and the symptoms of allergic respiratory disease. The only effective measure for avoiding animal allergen in the home is the removal of the pet. Avoidance of pollen and outdoor molds can be accomplished by staying in a controlled environment. Oral antihistamine help reduce sneezing, runny nose, and ocular symptoms. Administered as needed, antihistamines provide acceptable treatment for mild intermittent disease. Antihistamines have been classified as first generation, which are relatively sedating, or second generation, which are relatively non-sedating. As expected, second generation antihistamines are preferred because they cause less sedation. The anticholinergic nasal spray, ipratropium bromide, is effective for the treatment of serous rhinorrhea. Intranasal decongestants such as xylometazoline and phenylephrine should be used for less than 5 days and should not be repeated more than once a month to avoid rebound nasal congestion. Never forget this. If you repeat it more than once a month, or if you use it for longer period continuously, rebound nasal congestion will happen. Nasal saline irrigation is also adjunctive option with all other treatment for allergic rhinitis, because when you irrigate the nose, you remove the allergen. Patients with more persistent fever symptoms require intranasal corticosteroids. These intranasal corticosteroid agents reduce the symptoms of allergic rhinitis with eosinophilic inflammation, but they not reduce those of rhinitis associated with neutrophils or free of inflammation. Regarding prognosis, the reported rate of remission among children are 10 to 23%, and the therapy with non-sedating antihistamine and topical corticosteroids, when taken appropriately, improves healthy related quality of life measures in patients with allergic rhinitis. Thank you for watching.